welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is homocystinuria. Now, to help us understand this disease in a little bit more detail, we have with us today Dr. Anup Rawool, who is an Associate Director, Medical Genetics and Head, Scientific and Medical Affairs at MedGenome. He has over 12 years of experience in the field of clinical and molecular genetics. And Dr. Anup operates at the forefront of advanced technologies and techniques in genetic medicine. His comprehensive skill set basically includes precision medicine, medical genetics, cancer genomics, reproductive genetics, metabolic genetics, genetic testing, and even genetic counseling. Now, driven by a deep-seated passion for making a tangible impact in the lives of individuals affected by genetic disorders and cancers. So we welcome you to Medical Dialogue, sir. It's really a privilege to be interviewing you here today.
Yeah, thank you so much, Dr. Nandita ma'am, for the kind introduction. It's a privilege to be on this platform and to speak on one of the rare disease, which is apparently rare, because many times investigations are not done, so you tend to miss it. So that is the crux of it. So today I'll be speaking on homocystinuria. Brief insights into the genetic aspect and the management aspect. So what's so unique about homocystinuria is it appears to be rare, but clinically, if you see, even for heterozygous variants, it is found in in your clinical practice. And what is more important is it is manageable. If you diagnose it, you can treat it. That's the thing. And secondly, if you have found underlying genetic abnormality, then you could screen at-risk individuals, and management becomes easier. And again, genetic testing only in certain cases to ascertain. Otherwise, if you do biochemical screening, that also gives you sufficient evidence to go about the management. So basically, what is homocystinuria? It's a rare autosomal recessive metabolic disorder. Basically, it is a disorder affecting the methionine metabolism. So the description of this condition goes as back as 1962, and there are two subtypes. Classical one, which is predominantly the deficiency of the cysteine beta synthase deficiency. That's the CBS deficiency. And then there are rarer forms, which are due to underlying genetic abnormalities, which give rise to enzyme deficiencies which are involved in the methionine metabolism, the methionine homocysteine cycle. So globally, this incidence of homocystinuria is about 1 in 200 to 300,000 live births. And this is a very close differential of Marfan syndrome. So previously, many patients with homocystinuria used to clinically get diagnosed as Marfans because of having a Marfanoid habitus, Marfan-like features, skeletal abnormalities, dislocation of the lens, and so on. So next slide, please. As we discussed, homolysis. So there's a cycle that goes on where there's a conversion of methionine to homocysteine, and then later on, either this homocysteine gets remethylated to methionine, or then it gets transsulfurization to cysteine. So these are the two ways in which homocysteine levels are controlled in the body. And the key enzyme involved is cystathione beta-synthase. Then there are other enzymes that have been mentioned, which are important in the methionine homocysteine cycle, which code for different enzymes in each of those stages in the cycle, which we will see subsequently. And then there are certain cofactors which are important for functioning of those enzymes, particularly B6, pyridoxine, B12, cobalamin, and folate. So even deficiency of these vitamins can trigger homocystinuria, which is easily manageable if you diagnose it. And the underlying pathophysiology is CBS deficiency. So what happens is, since homocysteine is not able to undergo remethylation into methionine, or again transsulfurization into cysteine, there is accumulation of homocysteine that occurs in the body. And the basic mechanism through which homocysteine affects multiple organs is by disrupting the collagen cross-linking. So basically, it targets the underlying connective tissue at various locations in the body and causes manifestations. So particularly the vascular system causing thromboembolism, the skeletal system, the musculoskeletal system, of eyes, the dislocation of the lens, and the central nervous system. So this is inherited in autosomal recessive pattern, and as we have seen, the gene coding for the CBS enzyme, the CBS gene, that is the classical homocystinuria. So this gene is located on chromosome 21q, the region being 22, 22.3 the band, and over 200 mutations or pathogenic variants have been reported in this gene. So any abnormality in CBS gene will give rise to a abnormal CBS enzyme, so affecting the methionine homocysteine metabolism, and simultaneously other genes such as MTHFR, MTR, or MTRR, which are important for adjoining cycles that go on which support this methionine metabolism, uh, can affect this cycles, causing impaired folate metabolism or disruption of this remethylation of homocysteine to methionine. And then various pathogenic variants have been reported, so for these genes. So these could be like missense, nonsense. So this is more of the structural abnormalities that happen at the DNA in these genes. So these are the different genetic nomenclatures for those genetic abnormalities. So this is the methionine metabolic pathway. Basically, in simple words, whatever dietary amino acids are absorbed, so methionine is converted into homocysteine, and this homocysteine has two endpoint to either get converted into cystathione via the CBS enzyme, that is the major output that happens from homocysteine, or through B12 and folate dependent other pathway, beta independent pathway. There is a remethylation that happens from homocysteine to methionine. So then if there is a disruption, depending upon what is the molecular abnormality in this CBS gene, uh, it results in uh, the phenotype where this enzyme levels are affected. So depending upon if there is a minimal enzyme function that is remaining or it is totally deficient, it manifests into various phenotype, or it's a spectrum from mild to severe. So where a certain amount of enzyme function is retained, it gives rise to milder forms, and there are various these particular pathogenic variants are amenable to or may be treated by pyridoxine. So the classical clinical picture is pyridoxine responsive seizure disorders that happen. Then there are certain genes which influence the phenotypic severity, like the MTHFR polymorphisms. So again, affecting the clinical phenotype. And the usual systems that are affected that we've seen: eyes leading to ectopia lentis, marfans like habitus or marfanite features, tall stature, pectus, and so on, and intellectual disability, and predisposition to thromboembolism, particularly thrombosis, and osteoporosis. So this classical CBS deficiency, it typically involves multiple system, but again it's a spectrum. Variability of expression is known. So in some cases, it could be like only one or two organ systems are involved. When the presentation is severe, multiple systemic involvement is seen. Can we have the next slide, please? So how do we diagnose homocystinemia? So basically, biochemical screening tests come in handy. So looking at three parameters particularly: plasma homocysteine, methionine, and cystathione levels, and urine organic acid chromatography to look for elevated homocysteine. So these are the screening tests sufficient to clinically diagnose this condition. And targeted mutation analysis can be done, particularly for CBS gene. And if CBS gene we don't find any pathogenic variants, then Other genes which are important for methionine homocysteine metabolism, the cycle. So particularly MTHFR, MTR, and MTRR genes can be related. So there are some labs offer separate panels where we look at the test is focused on these particular genes, or something like a exome analysis could cover these genes and also the other differentials that are there. Again, in newborn, we can screen for the elevated methionine levels by TMS. So typically, when we're looking, we look at the total homocysteine levels and the methionine levels. So this is the methionine homocysteine metabolism cycle in detail, where the conversion to methionine to homocysteine is governed by two enzymes, S-adenosyl methionine and S-adenosyl homocysteine, and the remethylation is again catalyzed by the folic acid derivatives. And from homocysteine to cystathione, the output that happens, that is again catalyzed by the CBS enzyme. So any abnormalities in the main gene, that is CBS, or other genes which are involved in this metabolism could give rise to homocysteinemia. And then there are close differentials. One is the clinical ones, particularly Marfan's, where the underlying abnormality is in FPN gene, and the clinical features are something similar, because again it's a connective tissue disorder, but there is no propensity to vascular anomalies, the thrombosis component that is seen in Marfan's. And again, the biochemical abnormalities won't be seen in Marfan's. Then another connective tissue disorder, that is Ehlers-Danlos, which has an overlap with Marfan's. Again, there is a similarity with like joint hypermobility and skin elasticity. But however, again, the biochemical screens are something important that will help us to screen out. Then atypical homocysteinemia due to MTHFR mutations or B12 or pyridoxine deficiencies can be there. Again, looking at levels for this vitamins can be important. Next slide, please. So depending upon the diagnosis, the treatment is pretty straightforward. So if we identify any deficiency of the vitamins, supplementing them is important. Pyridoxine has a very important role, particularly in those pathogenic variants which are responsive to pyridoxine supplementation. So there are set of pathogenic variants that have been identified in the CBS gene, which are amenable to pyridoxine supplementation. And the basic mechanism is it augments the residual activity of the CBS enzyme. Again, betaine supplementation facilitates the remethylation of homocysteine to methionine. So whatever homocysteine is accumulated, either it is converted to cystathione or it is remethylated to methionine. Again, folate and B12 supplementation in case of remethylation defects, particularly if there is a pathogenic variant in MTHFR or MTR genes. Then there are certain like more of theoretical scenarios where we there are studies going on for gene therapies, ongoing trials for severe gene mutations. So more of a research area. And then potential future treatments, like since now we are focusing on genetic disorders where if there is a common or hotspot pathogenic variant that is known, can we manipulate or correct those underlying molecular abnormalities with technologies of gene editing like CRISPR-Cas. So that is a area of research. And to supplement this, to limit the homocysteine accumulation, important is to reduce or restrict the methionine intake in diet. And where there is a risk of thrombosis, antithrombotic therapy, particularly blood thinning agents, what we call in our this thing, aspirin and heparin. So again, particularly those individuals who are diagnosed with homocysteinemia, usually in clinical practice, the therapy or the treatment is only limited to those individuals. But we have to remember that for people who are diagnosed with homocysteinemia, there could be other family members at risk for whom screening becomes very important, and particularly in geographical pockets where consanguinity is common. Since this is an autosomal recessive condition, if you have homocystinuria in such pockets, you have identified, screening of a wider individuals or second degree, third degree members in the family becomes very important. Prenatal testing, though like matter of debate here, because conditions which are treatable, prenatal testing is not indicated as such. But if gene variants have been identified, refractory or severe phenotype condition exists in the family, in those cases, yes, prenatal testing by either CVS or amniocentesis for pathogenic variants in the CVS gene may be offered. Then, but in the limitation in prenatal diagnosis is like if the fetus is affected with that genetic abnormality, then a medical termination remains the only option for the couple. So here you can offer another option, that is the couple going in for IVF and we doing pre-implantation genetic diagnosis on the embryos, selecting the healthy embryos and carrying forward the pregnancy. So this is one option that can be offered to the families, particularly where the pathogenic variants are known. Now, since this is a autosomal recessive condition, the couple, families at risk need to be educated that the risk of recurrence in subsequent pregnancies will be 25% if both the parents or the couple is carrier. So, genetic counseling, yes. So, when we talk of any genetic test, the definition of genetic test is never complete without pre and post test genetic counseling. So, counseling, particularly covering the aspects of the disease phenotype, the disease spectrum, the clinical features, the red flags, the biochemical screening, newborn screening where appropriate, molecular genetic testing where indicated, and passing on the information regarding the probable tentative post-test outcomes and its implications, along with psychosocial support, should be discussed in detail with the family. Next slide, please. So, yeah, so like any other genetic rare genetic disorder, gene therapy, gene editing technologies remain an interesting avenue of research going forward. So, particularly for rare diseases where outcome is where when there is a pathogenic variant and outcome is very not so good. In those situations, these technologies come in very handy. So, area of interest for research, all this, and there are certain ongoing studies, particularly enzyme replacement therapies and in vivo enzyme synthesis. That is the area of research that is particularly being evaluated right now. Next slide, please. So, to summarize, homocystinuria is autosomal recessive condition, genetically heterogeneous since there are multiple genes, CBS being the primary gene, and again there is a variable phenotype, particularly depending upon what particular underlying gene is involved, what particular pathogenic variants are involved. So, early diagnosis is important for personalized management. So, even biochemical screening of the homocysteine levels along with methionine and cystathione can be very important. Out where the levels are borderline or uh, prenatal diagnosis is being or pregnancies at risk pregnancies, that in those situations molecular genetic testing can be done. And again, there is area where ongoing research for gene editing technologies is going on. So that's the area of research for future therapeutic interventions. Thank you.
Thank you so much, Dr. Anup, for giving us all your valuable insights on this rare disease. And I hope this is going to create lot and lot of awareness among the population to actually get diagnosed and medical professionals to get to know what it is and get to early diagnosis and provide according treatment. So thank you so much for joining us today at Medical Dialogues. It was lovely to be interviewing you here today.
Thank you, ma'am. Thank you so much for this opportunity.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.